Good afternoon. Today's been a very interesting day at C3. We had our symposia on the Cobra stent and the management of high-risk bleeding patients. It's sort of fascinating that over the last 23 years since I was a fellow, we've come full circle on the duration of DAP therapy. We started in 1995 with 2 to 4 weeks of therapy when we had the bare metal stents, and over the next several years we maintained it at 2 to 4 weeks when we realized that endothelialization occurred within 2 to 4 weeks in bare metal stents. Then in 2003, when we had the development of the drug-eluting stent, we increased DAP therapy from 9 months to 12 months, and then with some studies up to 30 months with the DAP study. And then over time we've realized that shorter is probably better in the latest generation of DES stents, and now we've come full circle back to 2 to 4 weeks of DAP therapy. For the last several years we've had two options. We've had bare metal stents or we've had drug-eluting stents. But in the high bleeding risk patients, where the patients who are elderly or who are on oral anticoagulation or who are anemic or who have valves or other issues that increase the risk of bleeding, we've had no other options. Well, now we have an option. It's the Cobra PzF nano-coated stent, which is a cobalt chromium stent, thin struts, produced by Celanova, which provides a sort of an intermediary option between bare metal stents and drug-eluting stents. So, Dr. Meraj, when you take care of patients and you have a patient who is either bleeding or is a high risk of bleeding, what is your strategy? How do you differentiate between the risk of stent thrombosis versus the balance to prevent bleeding in these patients?
I think it's a great question, and you really have to take into account both the lesion characteristics and the patient characteristics, and it's not just taking into account. So, of course, you're worried about lesion characteristics that may predispose you to stent thrombosis, such as smaller vessel sizes, longer length of stents, and obviously the patient's ability to take a long-term duration DAP therapy if it's necessary with drug-eluting stents. And so if you take all that into account and then you take the patient characteristics into account, you may come to the conclusion that a drug-eluting stent may not be the best option. And we all know that the bare metal stents today are really not safer than drug-eluting stents. So we need to find that special niche product which can help these patients, these higher bleeding risk patients, who cannot afford to take long-term DAP therapy, really not have long-term risk of stent thrombosis. And that's really where the Cobra PzF Stent comes into play. So as a convoluted answer that is, there really is no answer to the question. It's just a matter of taking into account on a case-by-case basis and saying, this particular patient may not be best suited for drug-eluting stents, so let's try something different.
I mean, if you think about it, right, most of the trials to date have not included the high bleeding risk patients, and they've just included general population, and we've extrapolated that data to the high bleeding risk patient. Except for the senior trial and maybe a couple of small trials, really most trials to date have never included the patients that are at highest risk of bleeding. So, Dr. Gandotra, do you use bare metal stents in any of your situations in your job when you see a patient?
I think it's rare. I think the percentage of usage of bare metal stents is less than 5% in a fairly busy cath lab. But I think your point of the patients, we look at the Synergy trials, we look at the other Onyx trials as well with Medtronic and the Boston Side stents. You definitely see that those stents they work well. There's a very low risk of stent thrombosis. Yet, that trial data was, as you said, that those patients were actually very sub-selected. We were part of most of these trials, or we are part of most of these trials, and we know the selection criteria is very stringent. And hence, I think the population that we are treating is getting sicker, and they're older patients, TAVR patients, 90-year-old patients. I think those are really truly the patients where we will be able to use this data and this Cobra stent much better than the other drug-eluting stents. Even though the argument from the general population will be that we can do a 1-month DAPT and we should be okay with the drug-eluting stents. they're correct, but that's only for those subselected patients.
Interesting. Now, what about the situation where you have a patient, you put a stent in 10 days ago, comes back with what seems to be a GI bleed? What do you do then? How do you decide when to continue the DAP therapy versus stopping it for a certain period of time with the understanding that there's a slight increased risk of stent thrombosis?
I think for me, the key there is how aggressive is your GI service. I think the testing that's involved and the ability to actually diagnose the issue first is the way to really go. First you diagnose, and if it's, as you've already actually said this, if this is a hemorrhoidal bleed or something else, you can certainly continue these patients on the DAP therapy and get away with it. But clearly, if it's a significant upper GI bleed, ulcerative bleed, or something a lot bigger, that's a different story. But I think from a safety perspective, I think we've started to become more and more comfortable in stopping the therapy and the dual antiplatelet therapy in these patients. 10 days, it's concerning, but that's when you monitor these patients very closely in the hospital and see if they actually do well. And I think, looking at what we've seen, I think they probably will do well.
So the real question becomes then is, how are we going to take care of these patients going forward? So we all know that bare metal stents the use of it is very low. So, and we all know that all of us, both up here and the majority of interventionalists, use drug-eluting stents for the vast majority of their PCI. So where do you see this kind of device really being used? And how do you think we're going to get more recognition for maybe its use in the right patient population?
So I can tell you from my perspective in our cath lab, we have essentially stopped using bare metal stents. So when there's someone who is at high risk of bleeding, and again, we always weigh the risk of thrombosis versus the risk of bleeding. And if the risk of bleeding is higher, we essentially don't use a bare metal stent, which has now been transferred over to the Cobra stent. So we use our Cobra stent essentially where we did the bare metal stents. And in 2018, I believe it's more of a niche product. I don't believe that anyone would recommend using it routinely on every patient. Although the data from eCobra in Europe, which you presented earlier today, was very fascinating. But I think in the right patient subset and the right lesion subset, I think it's a terrific opportunity to treat the patient in the right situation with the right stent.
And I think also the Cobra Reduce data will be very helpful because we do have a lot of elderly patients on anticoagulant therapy, and now also they're receiving interventions because of TAVRs or whatever else, or post-TAVR. So I think that patient subset will be the key in really creating the niche that this product is, I think.
I think that's a very, very good point. Right now, if you went to 10 different cath labs in the country and said, okay, someone's on Coumadin or a NOAC, they put a stent in, what is your process? What's your policy of dual antiplatelet therapy? One lab would say 1 month of aspirin, followed by of triple therapy, then followed by Plavix and a NOAC. Others would say just Plavix and NOAC based on the WOS study. Others would say baby aspirin plus Plavix and NOAC. So there's so many different variabilities and variations in the protocol that I think the Cobra Reduce will answer a lot of questions for us on how to treat these patients.
Absolutely.
I think it's going to be more interesting when, as we all know, the Leaders-Free study is coming to the U.S. And so when that stent hits the United States market, it'll be interesting to see that's how it's been touted in Europe, using it in that patient population. But looking at the eCobra data and looking at the Leaders-Free data from Europe, you can clearly see that the patient populations, albeit very similar, not perfectly identical, one's a randomized trial, one's a registry, but you can see that the data was better than I think most people would expect it to be, albeit the Leaders-Free is a drug-coated stent. It's not a no polymer base, so it's a slightly different technology. So it'll be interesting to see how that plays out in the U.S. market because, as you said, it's a niche concept, but something tells me that this patient population, as we're all seeing, is larger than we used to see. We're taking care of more of these patients and we're doing more of these patients than we used to do. So
I think this thromboresistant polyazine F coating is a fascinating idea that I hope is expanded to beyond the coronary stent. I mean, using it in a with the PFO closures, or on a TAVR, or on using that product on a Watchman device, may provide some added benefit. I think it has future benefits. So anyway, I think we can conclude that the Cobra stent is a good niche product in 2018. I think we can conclude that patients who are at high risk of bleeding may benefit in terms of morbidity and mortality, in terms of bleeding, with using a 2 to 4 week DAP therapy. I think we are excited about the fact that the Cobra Reduce study is going to be coming out in the next several months, which will look at triple therapy and 14 days of DAPT with patients with getting the Cobra stent, as compared to standard DES therapies of 3 to 6 months at least. So I think the times are exciting. I think it's a good time to be an interventional cardiologist, I'd say. And anything else you'd like to add?
It's been a great meeting. Thank you.
Thank you very much.
Thank you, Dr. Dave.